Okay, so good morning, everyone. So first, I would like to thank the Postgrad Committee for inviting me to become a speaker this year. So my lecture for today is entitled Vascular Dose of DOACs, the VOYAGER PAD Trial. So VOYAGER PAD is a study about rivaroxaban in patients with peripheral arterial disease after revascularization. So this trial was published in the New England Journal of Medicine just last year. So most of my slides can be downloaded actually in this website, www.cpcclinicalresearch.org. And the slides were actually used in the American College of Cardiology virtual scientific sessions just last year. Okay. So Voyager PAD stands for Vascular Outcome Study of Aspirin along with rivaroxaban in endovascular or surgical limb revascularizations for peripheral arterial disease. So before we start with the actual study, let me give you a brief background as to how the authors came about doing this research. So we know that PAD is becoming more prevalent with more than 200 million people globally having lower extremity arterial disease, and the incidence is still increasing. And we know that although the underlying disease states of atherosclerosis is shared with the more common types of diseases such as coronary artery disease and cerebrovascular disease, it is increasingly clear that PAD represents a distinct disorder characterized by a high risk of adverse limb events, including acute limb ischemia and major amputation, as well as major adverse cardiovascular events. So limb symptoms actually range from severe claudication, which limits function, to critical limb-threatening ischemia that is treated with revascularization to prevent or limit tissue loss. In contrast to coronary intervention and myocardial infarction, which are already popular, peripheral revascularization and critical limb-threatening ischemia are becoming more common nowadays. So patients who undergo peripheral revascularization are at a high risk for subsequent vascular complications, particularly for acute limb ischemia. And as you can see here, patients who undergo revascularization are actually at a high risk for acute limb ischemia to about as high as 4 times the risk. Okay, and we know that acute limb ischemia is actually a serious complication that is associated with long hospitalization stay and high incidence of limb loss, disability, and death. So despite the high risk, currently there is no proven antithrombotic strategy that has demonstrated efficacy for reducing major adverse limb events after peripheral intervention for ischemia. And so, in the previous years, they found out that by inhibiting thrombin-mediated activation of platelets with vorapaxar, this reduced the risk of acute limb ischemia in patients with stable PAD, and that this indicated that the risk for this complication is actually modifiable. And subsequently, in the year 2017, the COMPASS study, or cardiovascular outcomes for people using anticoagulation strategies trial, showed that a low-dose anticoagulant such as rivaroxaban at a dose of 2.5 milligram twice daily added to aspirin actually reduces the risk, the ischemic risk, including the risk of major adverse events affecting the limbs in a broad population with chronic PAD who are stable and with polyvascular disease. And so, on the basis of these observations, the authors of the Voyager PAD study decided to do this trial with the objective of testing whether rivaroxaban of the same dose, 2.5 milligram twice daily, added to low-dose aspirin, will reduce the risk of adverse limb events and cardiovascular events as compared to aspirin alone, and to evaluate its safety also as compared to aspirin alone. So they actually enrolled symptomatic patients with lower extremity PAD undergoing peripheral revascularization, and all of these patients were given aspirin 100 milligram per day. Clopidogrel was also given at the investigator's discretion, and these patients were randomized into a 1:1 ratio of rivaroxaban 2.5 milligram twice daily versus placebo in addition to aspirin. And they were followed up every 6 months, event driven, and the median follow up of 28 months. So the patients included in this study were patients who were at least 50 years of age with documented PAD, including those with ischemic symptoms, and with imaging evidence of significant occlusion and with evidence of abnormal ABI of less than 0.9. And of course, those who underwent successful lower extremity revascularization for ischemia. So they excluded patients who were asymptomatic and were revascularized, or those who had recent revascularization or acute limb ischemia or ACS, those with current major tissue loss, those with need for antiplatelet or anticoagulant other than aspirin and or clopidogrel, those who need long-term dual antiplatelet therapy, and those for high risk of bleeding. So the primary outcomes of this study included the presence of acute limb ischemia, major amputation for vascular cause, myocardial infarction, and ischemic stroke or CV death. Secondary outcomes included ALI, amputation, myocardial infarction, ischemic stroke or coronary death, unplanned index limb revascularization for ischemia, vascular hospitalization for a coronary or peripheral event of thrombotic nature, all-cause mortality, all stroke, and venous thromboembolism. So for the safety outcome, the principal method of outcome used the TIMI score for major bleeding, and the secondary outcome uses the ISTH criteria. So they were able to enroll 6,564 patients in 34 countries between the year 2015 and 2018. So among these patients, they were again randomized into 1:1 ratio of rivaroxaban versus placebo with a median follow-up of 28 months. And the primary and secondary outcomes were evaluated. For the patient's baseline characteristics, they were well balanced between the two groups. The median age was 67 for both groups, and 26% were females. So the risk factors were common in that 40% of the patients also had diabetes. Majority of the patients were Caucasian, and second most common risk factor is actually smoking. So approximately 2/3 of patients had been treated with an endovascular procedure, 66 for the rivaroxaban group and 65 for the placebo. And those who underwent surgical intervention was similar for both groups of 35 patients. So the primary outcome for these patients, again, included those who have had acute limb ischemia, major amputation for vascular cause, myocardial infarction, ischemic stroke, and cardiovascular death. So as you can see here in the Kaplan-Meier analysis of the primary composite efficacy outcome is that the primary composite outcome occurred in 508 patients in the rivaroxaban group and 584 patients in the placebo group. And that the Kaplan-Meier estimates of the incidence at 3 years were 17.3% for the rivaroxaban group and 19.9% in the placebo group, with a confidence interval of 0.76 to 0.96 and significant p-value of 0.009. So as you can see, again, those who were given with low-dose rivaroxaban plus aspirin had lower limb and cardiovascular events. So again, this is the primary efficacy outcome wherein there's lower event rates in 3 years among patients who were given rivaroxaban, and there were lower patients who have had acute limb ischemia, major amputation, ischemic stroke, MI, although in CV death, there was a slightly higher number in patients who were given rivaroxaban, but it was not significant. As for the secondary outcomes, So the incidence of the first 5 secondary outcomes in the testing hierarchy were all significantly lower in the rivaroxaban group, which is represented by the purple bars. So this includes the incidence of unplanned index limb revascularization for recurrent ischemia. And all-cause mortality, as you can see here, was not lower in the rivaroxaban group than in the placebo group. They were similar. There were no heterogeneity in the efficacy of rivaroxaban plus aspirin as compared with aspirin alone for the primary outcome across major subgroups, including those based on the age, sex, and cardiovascular risk factors. So similarly, there was no heterogeneity also in the type of intervention that was done in the patient, as well as in the ABI screening or the presence of critical limb ischemia at index revascularization. So when it comes to primary safety outcomes, TIMI major bleeding included the presence of intracranial bleeding or clinically overt signs of hemorrhage associated with a drop in hemoglobin of more than 5 grams per deciliter or an absolute decrease in hematocrit of 15% and or fatal bleeding. Whereas the ISTH major bleeding criteria included fatal bleeding or symptomatic bleeding in a critical area or organ such as intracranial, intraspinal, intraocular, retroperitoneal, intraarticular or pericardial, or intramuscular with compartment syndrome. Bleeding causing a fall in hemoglobin level of 2 grams per deciliter or more, or leading to transfusion of 2 or more units of whole blood or red blood cells. So the principal safety outcome of TIMI major bleeding during follow-up occurred in 62 patients in the rivaroxaban group and 44 patients in the placebo group, with a Kaplan-Meier estimate incidence of 2.65% in the rivaroxaban group and 1.87% in the placebo group, with a p-value of 0.07, which is not statistically significant. As we can see here, intracranial hemorrhage occurred in 13% of patients in the rivaroxaban group versus 17% in the placebo group. And fatal bleeding occurred in 6 patients in both groups. The composite outcome of intracranial hemorrhage and fatal bleeding occurred in 17 patients in the rivaroxaban group and 19 patients in the placebo group. There was no heterogeneity in the risk of TIMI major bleeding among the major subgroups. The secondary safety outcome of ISTH major bleeding occurred in 140 patients in the rivaroxaban group and in 100 patients in the placebo group. And the Kaplan-Meier estimates of incidence at 3 years was 5.9% in the rivaroxaban group and 4.06 in the placebo, which is actually significant. So as you can see, there is a difference in the safety outcome in these patients, wherein there is a slightly higher increase in incidence in the TIMI score events, which is not statistically significant. But again, in the ISTH group, there is a higher prevalence of bleeding, which is statistically significant. So in summary, in symptomatic patients after revascularization, about 1 in 5 patients will have acute limb ischemia, major amputation, ischemic stroke, MI, and cardiovascular death in 3 years. And in this population and setting, rivaroxaban of 2.5 mg twice daily with aspirin, as compared to aspirin alone, significantly reduces the risk with benefits apparent early and continued over time, is consistent among the major subgroups with broad benefits including reductions in unplanned index limb revascularization. However, again, there is a noted increase in bleeding using the TIMI major bleeding and with significantly increased ISTH major bleeding, but no excess in intracranial or fatal bleeding. So with this, the authors of this study concluded that giving rivaroxaban of 2.5 milligrams twice a day with aspirin prevents 6 times as many ischemic events relative to bleeds caused in PAD patients after revascularization. So this is actually a good thing in that we know that rivaroxaban may help us in preventing the following complications in our patients. However, of course, this is a relatively new study and there has been criticisms regarding this study, and I would like to share them with you also. So, of course, one of the things that we have mentioned earlier is the use of clopidogrel. The use of clopidogrel in this trial was actually under the discretion of the authors. And so, of course, the concomitant use of clopidogrel is actually a bias in this trial because there is no comparison against clopidogrel in these patients. And that, of course, all these studies are founded by Bayer, the drug company that produces rivaroxaban, and that there is a high percentage of patients who discontinued the treatment prematurely. Although, of course, the number was relatively balanced between the two groups, there was still a high percentage of patients who discontinued the treatment prematurely. There is, of course, the significantly higher incidence of secondary safety outcome of ISTH major bleeding in the rivaroxaban group, which we should not forget and should be taken into account when we give this to our patients. So in the end, given the trial and the criticism, do you think this study will change our clinical practice? In my opinion, I think that yes, it can change our clinical practice because one, now we know that aspirin alone is not enough and that there are better therapies out there that are waiting to be discovered, such as this one. Two, now we know that there is a role in giving anticoagulation in this subset of patients, such as PAD patients who were revascularized. And the three, we know that we can avoid giving aspirin alone to avoid cardiovascular and major limb events in these patients. So this is actually my last slide, and I would like to thank everyone for listening. If you have any questions, you may ask me anytime. Thank you.
Good morning. So let us welcome back Dr. Aileen for the question and answer portion. So far, we don't have any question in the chat box. So I'll throw in the first few questions. No, thank you, Aileen. True enough, as Dr. Paul has said, that we expect to hear some practice changing knowledge on this forum. No? So just looking at the study, I noticed that the rivaroxaban dose has a lower dose than what we are used to giving. We used to give 10, 15, or 20, but for this PAD, we are using 2.5 twice a day. So the question is it available already in our setting, or is it something that we expect in the near future?
Good morning, everyone. Good morning, Dr. De La Rosa. Thank you for inviting me again. So, yes, the lower dose in rivaroxaban in this case is actually, I think, based also on the results of the COMPASS study that was published in 2017. So the rivaroxaban 2.5 milligram is actually available already in our country, but in limited pharmaceutical branches only. So far, I have talked to Bayer, to the medical company producing rivaroxaban, and they said that if ever we need any help in getting the medications, we can ask help from them to procure it for our patients.
Okay, that's nice to know. So it is actually available already in our setting.
Okay.
Now, the other question I have to ask is this: is this exclusive for rivaroxaban, or I mean, is it true for the other NOAC available?
This study only used rivaroxaban, doctor, solely for rivaroxaban, and we have yet to look for other studies using other DOACs.
Okay, let's go to we have one question here from Dr. Bernardo. Did they include surgical bypass patient and not just endovascular therapy? And did they find the same benefit?
Yes, in this study, they included both surgical bypass patients and endovascular treatment groups. However, there was more patients who underwent endovascular treatment. Around two-thirds of the patients actually underwent endovascular treatment, and one-third underwent bypass treatment. So far, they found the same benefits, whether endovascular or surgical treatment, but they did not do a subgroup analysis in these patients. So they did not really specify whether the patients who benefited from being given rivaroxaban actually underwent which treatment. So this is actually one of the limitations that was found in this study.
I see. And another question is, the study included those who had revascularization. So the question is, there will be some patients, although we know that they have this problem, that they need this revascularization, but will not be able to do it for some reasons. No, can we apply it to those who will not be able to undergo revascularization?
Yes, doctor. I think that that would fall under the COMPASS trial, doctor, that was published in 2017. So in the COMPASS trial, they included patients with polyvascular disease, whether peripheral or coronary artery disease. And just the same, they tested rivaroxaban 2.5 milligrams twice a day together with aspirin. And in that same study, they also found out that there was a decrease in the risk for MACE, and there is an improved mortality benefit for these patients. And so I think it is applicable even in patients who have not underwent revascularization yet.
So that's really nice to hear. So we can apply it both for those with or without revascularization, because the reality is, in real practice, there will be some patients who will not be able to do it. Maybe for medical reasons, some maybe they cannot afford the procedures. So we can still give this medication for
Yes,
their benefit. So it's nice to know that now, before we use NOAC for atrial fibrillation, then deep vein thrombosis, and now we have the expanding role where we can use it also for PAD. So as you mentioned, aspirin is not enough.
yes.
Aspirin alone is not enough. There are other options where we will be able to help our patients with peripheral arterial disease. Let's see if we have some more questions. I see none. So wait, let me check lang. So there's one more question here. What drove the most benefit in both revascularization and high-risk PAD?
In both
This is a
revascular.
question from Dr. Bernardo. So what drove the most benefit both in the revascularization and high-risk PAD?
So in this study, in the Voyager study, doctor, they only included patients who underwent, all of them underwent revascularization. And the most benefit actually was found in the in decreasing the risk for acute limb ischemia and overall, and including actually DVT also. For high risk PAD, that is again one limitation in that uh, the types of the lesion, the location of the lesion, and again, the type of intervention that was done on the patients were not disclosed. And so that can be one confounder also in this study. But so far, most benefit was seen in decreasing acute limb ischemia and overall CV events.
Okay, we have one more question here. How long should this regimen be given? That's from Dr. Torres. So should we give it for a month, or is it for life?
In this study, the patients were followed up for a median of 28 months.
28. So that's more than 2 years, right?
That's more than 2 years. And that, for me, I think the most benefit would be if we follow this study to give it for patients up to 2 years. But then again, there's no study up to exactly the time frame for which we can give this medication. So I think we should be cautious about the length, or at least try to give it in the same length that the study was done.
So we can give it for 28 months, and maybe by the time we reach that point, maybe there will be new updates from the study
Yes, that's
regarding how long we should give it. So we'll just have one last question. This is from Dr. Las. What was the basis for giving a very low dose twice a day for a drug that has a once a day pharmacokinetics? So we all know that we give rivaroxaban 10, 15, 20 once a day. But for this, we are giving it 2.5, but twice a day. Why not just 5 milligrams once a day? I think that's the question there.
I think the so both studies, the Compass and the Voyager pad trial, actually did not mention anything about their basis for using that low dose. But if we are to check the half-life of rivaroxaban, the half-life is actually about 5 to 9 hours. So I think they just wanted to give a low dose of the medication to decrease also the risk for bleeding. Because remember, even if we have given this low dose to patients, there was still an increase in bleeding risk for them. So I think they tried to do it by giving a total of 5 milligrams per day, but divided into 2 doses. So maybe in the future, we can also try to see, or maybe they can develop another study if 2.5 once a day will also be enough.
Okay, so that's our last question already. Thank you, Aileen. So aspirin is not enough. We have other options. We can give it for 28 months. And beyond that, maybe we hope to have an update on the study, maybe a follow-up of this, of the participants in the same trial to see if we really have to extend beyond 28 months. Okay?
Thank you, Doctor. Thank you,
Thank you,
everyone.
Aileen. Thank you very much.